Assalamu alaikum. Good evening. So we meet again after a gap of 2 weeks. So unfortunately, I tried my level best, but somehow because of the technical problems, it happened in the last week. So I could not at all conduct the session. And now it is also happening this week. I don't know. I may be unfortunate. Uh, the video is not actually working. So I have to do it only with my screen sharing and my voice. So please forgive me if I miss anything. And obviously, I'm not at all comfortable in such situations, but it happens, and you have to go with it. So today's lecture is on epilepsy, actually, and it's a very important subject. It's not at all an unimportant postgraduate subject. Epilepsy is required in the undergrad medicine exam also, both in the medicine board and also in the pediatrics board. But today we are actually talking about adult epilepsy. So pediatric people have some other aspects regarding epilepsy, which I think will be discussed by them much better than me. So I will try to stick to my principle, that is anything that is applied with the adults. So let's start with the epilepsy. So actually, before trying to say what is epilepsy, we have to be clear of three closely related terms: epilepsy, seizure, and convulsion. So these terms are often used interchangeably, but these three terms are not actually synonymous with each other. So the most basic term is a seizure. So what it means? It means that it is a transient neurological symptom or symptoms due to abnormal discharge of a group of neurons in the cerebral cortex. That means in the cerebral cortex, a particular group of neurons starts being activated abnormally. And because of their abnormal activation or abnormal discharge, there are a few neurological symptoms, and those symptoms should not last very long. That is why we have used the term transient neurological symptoms. So this activation uh, will lead to symptoms, and both the activation and the related symptoms will not last very long. So this is the basic thing, that is a group of neurons in the cortex. They start discharging abnormally, which leads to some symptoms, and if the entire thing, the activation and the resulting symptoms will last for only short time. So that is why the definition comes from the transient neurological symptoms due to abnormal discharge of a group of neurons in the cerebral cortex. So this is called a seizure. On the other hand, uh, cerebral cortex has quite a few functional areas: the prefrontal cortex, the motor cortex, the sensory cortex, the visual cortex, the auditory cortex. So different areas. So according to the location of the neurons which are discharging abnormally, the symptom of seizure will vary. For example, if it affects the motor area, the symptoms will be some abnormal movement of the body or part of body. If it affects the sensory area, the symptoms will be abnormal sensation in the part of the body. If it affects the auditory area, there will be some abnormal sounds audible uh, to the patient. So there could be different types of neurological symptoms uh, according to the area of cortex activated. That means the abnormally discharging neurons are located in a particular area of brain, and the symptoms will depend on the function of that area. So that is why the seizure could be a motor seizure, could be a sensory seizure, could be a visual seizure. If it involves the temporal lobe, it may lead to psychic seizures. Even when the autonomic, the higher centers for the autonomic nervous systems are activated, it may lead to autonomic seizures. So among these different types, the most common one which we encounter is the motor seizure. And a motor seizure is called a convulsion. So convulsion is nothing but one type of seizure, the most common type of seizure we encounter. So the motor seizure is called a convulsion. And when someone has tendency to have seizures again and again, we call it epilepsy. So what is epilepsy? Epilepsy is nothing. It is only the tendency of recurrent seizures. So very simple. The first definition you should know is the seizure. That means transient neurological symptoms due to abnormal discharge of a group of cerebral cortical neurons. When the symptoms are motor symptoms, this is called a convulsion. And whatever the symptom is, when it occurs repeatedly, then we call it epilepsy. So I think the three terms are clear by the time. So let's go with the classification of seizure and epilepsy. So in different books, both in the undergrad and postgrad books, there is quite a clumsy classification of seizure or epilepsy. And there is a separate classification systems for seizure and epilepsy. But I think recalling or remembering every such detailed classification is quite difficult for an undergrad student. So most of the neurologists in Bangladesh has approved a more simplified way to classify seizures and epilepsy. So we'll go with that. A seizure or epilepsy can be classified whether the abnormal discharging pattern is occurring in a particular part of brain or whether this is occurring in the entire cortex. So when the entire cortex is activated, then we call it a primary generalized seizure or primary generalized epilepsy. On the other hand, when a part of the cerebral cortex is activated, it is called a focal or a partial seizure. So there is so many theories regarding how the entire cortex become activated. It is reasonable that a focal part of cortex can be activated because of a focal lesion like stroke or a tumor or head injury. This is possible. But how the entire brain, the entire cortex is activated simultaneously? It is hypothesized that the activation begins in the thalamus. So as thalamus is connected to the entire cortex, so activation in the thalamus leads to activation of the entire cortex. So this is the thalamus play a central role in the development of generalized epilepsy or seizure. So very simply, when the abnormal activation occurs in a particular area of cortex, it is called a partial or focal seizure or epilepsy. And when the entire cerebral cortex is activated together, it is called a primary generalized seizure or epilepsy. Again, this is I have already said that primary generalized seizure, there is no identifiable structural lesion in the brain or cortex. So, but in the focal seizure, there is a structural lesion often found in the cortex, and this is called epileptic focus. So this abnormal region starts discharging, this diseased region starts discharging abnormally. So the common causes that lead to focal seizure are stroke, brain tumor, encephalitis, brain abscess, tuberculoma. Tuberculoma is a space-occupying lesion in the brain because of tuberculosis, and obviously head injury. So we are people from medicine, although head injury is more common than many of the cases I have mentioned here, but we would like to put head injury below all the medical causes. So yeah, we are a bit biased regarding selection of the serial of the focal lesions, but I cannot do without it. So the focal lesion, in focal seizure, you have to look for a focal lesion, and sometimes the focal lesion is treatable. So that is why it is very important to distinguish whether the epilepsy is a focal one or a primary generalized one. But the things, the classifying the epilepsy into simply a focal and generalized is the primary thing. So what is a focal or partial seizure or epilepsy? When part of the cortex discharges abnormally, and it leads to symptoms occurring in a part of the body, okay, particular body part. On the other hand, in primary generalized seizure or epilepsy, the entire cortex discharges abnormally, so the symptoms will occur in the entire body. The importance of classifying seizure into focal and primary generalized is, in focal epilepsy, you have to look for structural causes which may be treatable. So neuroimaging is mandatory when the diagnosis is focal epilepsy or focal seizure. On the other hand, in generalized, primary generalized epilepsy or seizure, neuroimaging is unnecessary because we are not going to find any particular structural lesion in any part of the cortex. I have already said that the focal epilepsy is caused by a lesion in a part of the cortex. But generalized epilepsy starts from thalamus, and you need not to find any lesion in the cortex, which will be normal. But here is another interesting thing, that is sometimes cortical lesion, that means which is supposed to produce focal or partial seizure, can activate the entire cortex. How? Very simple. Uh, Entire cortex is connected to the thalamus. So when a cortical lesion or focal lesion in the cortex uh, can activate the thalamus, and through thalamus, then the rest of the cortex, the entire cortex gets activated. So this is we call a focal or partial seizure with secondary generalization, and it is also called a secondary generalized seizure or epilepsy. So before we named, that is primary generalized, it is entirely activation of the cortex without any focal lesion, and partial or focal. But here the entire cortex gets activated, but uh, it is activated after a particular part of brain gets activated because of a focal or epileptic focus. So through thalamus, the cortical focus can activate the entire cortex, and this is called a secondary generalized epilepsy or seizure. So secondary generalized epilepsy is actually a focal or partial epilepsy. It is not a primary generalized epilepsy. Uh, we are classifying it along with the focal epilepsy because, like the other focal epilepsies, you may find a cortical lesion here. So in secondary generalized epilepsy, just like focal epilepsy, you have to go for neuroimaging studies. So if we now try to classify the types of focal or partial seizures, we can classify them into three basic types: simple partial, complex partial, and secondary generalized. So what is a simple partial seizure or epilepsy? Very easy. That means when, first of all, a partial seizure means that the neurological symptoms will limited to a particular part of the body. So that is fine. In addition to this, in simple partial seizure, there will be no impairment of consciousness. Okay, so there may be jerking of one half of the body or abnormal sensory feelings in one limb like this. A particular part of the body is involved, but the consciousness is intact all the time. So this is called simple partial seizure or epilepsy, and it usually occurs in partial seizures originating from the frontal or parietal lobes. On the other hand, when partial seizure or epilepsy is associated with some impairment of consciousness, is called complex partial seizure or epilepsy. So complex partial seizure or epilepsy usually occurs in the partial seizures originating within the temporal lobe. So let me just check it. That is, simple partial means focal epilepsy, focal seizure without loss of consciousness. Commonly occurs in frontal or parietal lobe lesions. On the other hand, complex partial means focal epilepsy with impairment of consciousness. Commonly occurs in temporal lobe lesions. And finally, secondary generalized seizure or epilepsy. That means focal seizure leading to generalized seizure. We have already talked about it. So focal seizures are of three types: simple partial, complex partial, and secondary generalized. Now let's classify the primary generalized seizures. So there are basic four types of primary generalized seizures. The most common type is generalized tonic-clonic seizure or GTCS, and there are other types also: absence seizure, myoclonic seizure, and atonic seizure. So the generalized tonic-clonic seizure is the most common type of primary generalized seizure. I must mention here also that in secondary generalized seizure, which is a type of primary generalized type of a partial or focal seizure, the seizure type is always generalized tonic-clonic. Okay. So the other three types we find, like absence seizure, myoclonic seizure, or atonic seizure. These three types we will find only in primary generalized seizure. But in secondary generalized seizure, which is actually a focal seizure, the seizure type will be generalized tonic-clonic. Okay, so now we will have a short description of principal types of seizures. So let's start with the most common type of seizure, that is generalized tonic-clonic seizure. It is also called grand mal seizure. Okay, so in many older literatures, they use the term grand mal seizure. So if you are asked in the exam, you should be able to answer. If you are asked about, okay, tell me the stages of grand mal seizure, then you have to start with the stages of generalized tonic-clonic seizure. So actually there are 5 stages of GTCS, and the first stage is aura. It is followed by a tonic stage, then a clonic stage, followed by a relaxation stage, and finally the recovery stage. So there are 5 stages of generalized tonic-clonic seizure. The first stage is called the aura. Okay, so it is nothing but an abnormal sensation felt by the patient. It may be an abnormal smell, an abnormal sound, or an abnormal tactile sensation. It can be anything. Very brief but abnormal sensation perceived by the patient. And remember, this first stage, that is the aura stage, never occur in the primary generalized epilepsy. It occurs only in the secondary generalized seizure. I have already said that generalized tonic-clonic seizure is the principal type of primary generalized seizure, and it is the only type in secondary generalized seizure. So the next step is the tonic stage. In tonic stage, there is sudden increase in tone of all the muscles of the body. So all the body skeletal muscles go into a state of sustained contraction. And this leads to loss of consciousness and the patient falls suddenly. As there is cessation of respiration because of sustained contraction of muscles, there will be no diaphragmatic movement. So definitely there will be cessation of breathing. The patient usually develops cyanosis. And because of the sudden fall, it is the first stage, second stage, that is the tonic stage, the patients usually develop injuries and commonly head injuries. So the important thing that is, this is the first stage in primary generalized seizure, because aura will occur in only secondary generalized seizure. So what happens in tonic stage? There is sustained contraction of all the muscles of the body. The patient falls suddenly, sustains some injuries, commonly head injuries, and also the patient develops central cyanosis. Okay. The patient will appear blue. It is followed by the clonic stage. In clonic stage, there is uh, alternating contraction and relaxation of the body muscles. So it will lead to some jerky movements of the body. And during this stage, due to repeated contraction relaxation cycle, patients develop tongue bite. So tongue bite usually occurs in the clonic stage. On the other hand, cyanosis and injuries, other head injuries, they occur in the tonic stage. The clonic stage will lead to the relaxation. Now, uh, the seizure activity has ceased. So there will be relaxation of all the muscles of the body. And as all the muscles of the body will get relaxed, so there will be loss of sphincter tone. And because of the loss of sphincter tone, the anal and the urethral sphincters, they will get loose. So there will be incontinence of urine and incontinence of feces. So in relaxation stage, actually there is no seizure activity, but the patient will have still the symptoms, that is there will be incontinence of urine or incontinence of feces. So important thing in the three stages are, in tonic stage the patient has fall, head injuries and cyanosis. In clonic stage the patients have jerky movement and tongue bite. And in the relaxation stage the patient has incontinence of urine and feces. So the relaxation stage is followed by the recovery stage. Now the patient is recovering. So usually the recovery is gradual, it is not sudden. It takes about 30 minutes for the patient to recover completely. And sometimes the patient feel some headache. So it is called the post-ictal headache. And on occasions, the patient may develop hemiparesis. Uh, this is actually a reversible hemiparesis. It should not last for a few hours. At best, it can last for 24 hours. So this reversible hemiparesis, it is called Todd's palsy. This may happen in many patients, and this Todd's palsy following a seizure is a feature of secondary generalized seizure. So two things in the description of seizure we found are only present in the secondary generalized seizure. One is the aura and another one is the Todd's palsy. So these things will never happen in primary generalized seizure. So overall, you have to, if you are asked to describe the stages of seizure, you should start from aura and then tonic, clonic, relaxation and recovery. But if you are asked a bit in depth, then you should mention that aura will occur only in secondary GTCS. It will not occur in primary GTCS. So if someone has a GTCS, it is very important to distinguish whether this is a primary GTCS or whether it is a secondary GTCS. why I have already mentioned, that is, in primary GTCS you will not need any neuroimaging studies. On the other hand, in secondary GTCS, the neuroimaging is mandatory, as secondary GTCS starts as a focal seizure and then becomes secondarily generalized. So this is the cause why it is very important to distinguish primary and secondary generalized seizures. So there are a few clinical points that indicates that this is a case of secondary GTCS. So presence of any of these clinical features favors the diagnosis of secondary GTCS, and then you will have to go for a neuroimaging study. So what are the clinical features that favors a diagnosis of secondary GTCS? I am telling it because in most of the cases of secondary GTCS, the primary seizure is nothing but the aura. So it is often not recognized by the onlookers. So what they describe is nothing but the secondary generalized tonic-clonic events. So you have to be very cautious to find whether this is a primary generalized or a secondary generalized, because neuroimaging is costly and it is a crime to not to do neuroimaging when the secondary generalized seizure is there. And it is also not decent to prescribe, to advise neuroimaging when the disease, generalized seizure is a primary one. So it is very important. So one point is focal onset. That means if they can clearly say that is the movement, the seizure started in one part of the body, then other parts got involved. For example, the seizure has started in right upper limb. So they will tell that the right upper limb started moving or jerking abnormally. Then after a few minutes, the entire body started doing it. So this is called a focal onset. Then the focal features during seizure. It means there are some asymmetrical things observed during the seizure activity. For example, the patient may turn the head or turn the eyes to a particular side. Okay. So it indicates a focal onset. Then obviously aura I have already said, and Todd's palsy. And if uh, after the seizure during clinical examination we find any abnormal CNS signs, it also indicates probably this is a case of secondary GTCS. And obviously primary GTCS usually occurs after 5 years of age and below 50 years of age. So presentation at the extreme of ages, that is below 5 years and after 50 years, should uh, indicate whether this is a case of secondary GTCS. So remember these 6 points. Presence of any of these 6 points uh, will put the patient in need of neuroimaging. Okay. Another important primary epilepsy type, generalized epilepsy type, is an absence seizure. It is also called pethimal seizure. So pethimal seizure, and this usually occurs uh, in young people. Usually it occurs at the age of 5 till the age of 12 to 15. So this is basically a generalized seizure in the very young people, the children. And most of the cases, this seizure usually stops occurring after the teenage. So what makes it special? It makes because it doesn't have so many motor abnormalities. What actually happens? The child stops the ongoing activities. That is what it was doing. The child just stops it and then stares blankly, just look blankly, and it occurs only for a few seconds, always than 10 seconds, usually 1 to 3 seconds, and after that the child starts doing what it was previously doing. And these are very slight abnormality, and there is no dramatic events like in generalized tonic-clonic seizure. There is no jerky movement of the body, there is no fall, there is no injuries. Only very subtle thing happening. There is the child just stops what it was doing, stares blankly, and then becomes normal. Very simple. And it is very brief, and there are numerous such episodes every day, usually in hundreds. Okay. So I have written 10 to 100. It may occur even more than 100 times, maybe 500 times. So it is less dangerous than generalized tonic-clonic seizure because there is no chance of injury. But the problem is because of such interruption of ongoing activities, the child usually cannot concentrate or cannot uh, take part in the academic activities, the school activities properly. So there is a gradual deterioration of the school performance. Often these children actually presents with gradual deterioration of the results of the exams. They are often uh, complained by the school teachers to the guardians that your kid is not giving proper attention to her studies. So this is like that. So this is a very special seizure, and you have to know it. Okay, so there is not much motor activities, rather just stopping what it was doing, and then staring blank, and within a very brief time, 1 to 5 seconds, it becomes normal again. And this is happening again and again, hundreds of times a day. Another type is atonic seizure. It is also called a drop attack. It is in fact uh, more transient than the absence seizure. It's very brief, fraction of a second it occurs. There is sudden loss of tone of all the muscles of the body and fall. And most of the cases, it is also very frequent. It occurs also over 100 times a day. So this is called atonic seizure. And obviously, there is fall in atonic seizure. So there will be head injuries. Very common in atonic seizure. In fact, head injuries occur more commonly in atonic seizure than in generalized tonic-clonic seizure, because generalized tonic-clonic seizure will not occur so many times a day. But this atonic seizure can occur 100, 500, 1,000, even more than that count a day. So this is a seizure that needs really early treatment to prevent head injury related problems. Finally, the last type of generalized seizure is myoclonic seizure. It is also very brief, and it does not involve the loss of tone of the muscle like atonic seizure. Rather, it is a jerky, very brief, electric shock-like jerky movement of a part of the body or the entire body. And there is no loss of consciousness. This is called a myoclonic seizure. So that makes the 4 basic types of generalized seizure, that is generalized tonic-clonic seizure, absence seizure, myoclonic seizure, and atonic seizure. Yeah, I think you will be able to understand the basic things. So let's now have a few descriptions of the simple partial seizure. And the simple partial seizure usually occurs in lesions of the frontal lobe or the lesions of the parietal lobe. And it is also called Jacksonian seizure or the Jacksonian march. So why the term march? It means uh, there is the seizure that will begin in one particular part of the body, and then it will spread to the other part of the same half of the body. So the simple partial seizure usually sometimes it happens in such that it begins in one part of the body and then involves rest of the body in that part. So it may start in the right hand, then spread to the entire right upper limb, then spread to the right foot, then finally involving entire the lower limb. So the entire right half of the body is involved. So it will be either a motor seizure or a sensory seizure, depending on whether the frontal lobe or the parietal lobe is the culprit. Okay. So if the epileptic focus is located in the frontal lobe, it will be a motor seizure. If the epileptic focus is located in the parietal lobe, it will be a sensory seizure. So it as it begins in one part and then spreads to the rest of the half, it is called a march. That is, seizure is marching from one part of the, it's moving, so like the march of the soldiers. So it is marching from one part of the body to the other part, and that is why it is often called the Jacksonian march or the Jacksonian seizure. Complex partial seizure originates in the temporal lobe. So this particular seizure has some similarities with absence seizure. The similarities is there is not much dramatic motor activities like in other types of seizures. Rather, what happens during a complex partial seizure is also called a temporal lobe epilepsy because the focus is usually located in the temporal lobe. The affected person stops the activities just like uh, happens in absence seizure, and then there will be some automatism. Automatism means some abnormal movement, but not very dramatic movement, abnormal movements of the body, like blinking of eyes, smacking of lip, making some abnormal noise to the mouth, then picking or trying to pick something with the hands, or even walking. So everything that is happening is not within the control of the patient. These are happening involuntarily, and these things are called automatism. Not all the types I mentioned here will occur in every patient. So different patients will have different types of automatisms. And these things last for a few minutes, and after that there is the recovery. So usually the recovery takes about 30 minutes, and there is no fall or no convulsion as in generalized tonic-clonic seizure. So this is complex partial seizure. It has some similarities with uh, absence seizure in that is sorry, there will be not much dramatic motor jerking of the body, or there will be just stopping of activities and some minor movements of the bodies, and there will be then gradual recovery after that. So this gradual recovery is different from what happens in absence seizure, because in absence seizure recovery is very rapid within 10 seconds, but in complex partial seizure it takes about 30 minutes for the complete recovery. Now we will talk about the seizure mimics. That means the conditions that are often confused with seizure, and it's very important to know the seizure mimics, because the seizure mimics are to be differentiated from seizure for the proper further management. So there are two basic conditions that are closely confused with seizure. One is a syncope, another one is a pseudoseizure. So syncope is similar to seizure because in syncope there is transient loss of consciousness, which occurs in generalized seizure also. On the other hand, in pseudoseizure, there are involuntary movements of the body or abnormal movements of the body, looking apparently involuntary, which occurs also in seizure. So these two conditions are often confused with uh, pseudoseizure, syncope and pseudoseizure. So actually what happens in seizure is in syncope, the basic problem in syncope is reduced blood supply to the brain. It is cerebral hypoperfusion. It leads to syncope, and pseudoseizure is a psychogenic phenomenon. So how we can distinguish seizure from syncope is very important. These points are really important. I think this and the next slide, these two are the most important slides of the today's lecture. That is, seizure will occur at different posture. So there is no relation of the posture with the seizure, but syncope usually occurs only in upright posture. So this is a very important point. That is, Whether the event occur only in upright position, it is syncope. And the patient usually in seizure, the patient usually appear blue. So in this slide it is wrong, please correct it. And in syncope, the patient usually appears pale. So please correct yourself, this particular slide. That is, the appearance of the patient will be blue in seizure because in the tonic stage there will be cyanosis, and in syncope the patient appears pale. And the involuntary movements, they are usually common in seizure, and they are very uncommon, and even when they are present, they are very minor type in syncope. Tongue bite and incontinence of urine and feces are very common in seizure. They do not occur in syncope. Seizure usually lasts only a few minutes, but syncope is a very short thing. Is usually the entire episode of syncope recovers in less than 1 minute time. The recovery is seizure is gradual, and the recovery in syncope is abrupt. So the patient loses the consciousness only for a very few seconds, always less than 1 minute, and after that the patient then just stands up. Nothing happened. So this is very important to distinguish seizure from syncope. The most important points are the posture and the duration and recovery, because seizure will occur in any posture, syncope will occur only in upright posture, and the recovery is gradual in seizure and it is abrupt, very sudden, very rapid in syncope. The points that distinguishes seizure from pseudoseizure. The most important point is the condition of the eyes, whether they are open or closed. In seizure, the eyes are always kept open. In pseudoseizure, the eyes are closed. And if you try to open the eyes, the patient will forcefully try to close it. Okay. And the movement pattern, the jerk pattern follows a particular way in seizure. It is bizarre in pseudoseizure. Tongue bite and head injuries are common in seizure. They never occur in pseudoseizure. Cyanosis occurs in seizure, in generalized tonic-clonic seizure. It will never occur in pseudoseizure. Seizure can occur in any circumstance, but pseudoseizure usually occurs only in front of others. So another important point is pseudoseizure will not occur in sleep, and seizure may occur in sleep, in wakefulness, in any condition. So these are the points that distinguishes seizure from pseudoseizure. The most important one is the eye, the tongue bite, head injuries, and cyanosis. So if eyes are open, there is any history of tongue bite, head injury, or cyanosis, it is obviously seizure. And if eyes are closed and there is no tongue bite, head injury, or cyanosis, it is likely to be a case of pseudoseizure. So let's get into the next thing, that is which investigations you should go for a case of epilepsy or seizure. First of all, I have to mention you that epilepsy or seizure is a clinical diagnosis, and lab investigations are needed only for selective cases. So you need not to go for investigations in all cases of seizure or epilepsy. So when you have to go for epilepsy investigations, the most of the cases when someone has a focal or partial epilepsy, that obviously includes secondary generalized ones, you have to go for MRI brain to detect any structural lesion. Okay. So the most important investigations in epilepsy is MRI brain, and you will not advise MRI brain to all epilepsy patients. Only when you suspect clinically that the patient may have a focal or a partial seizure, even a secondary generalized seizure, In that cases only, you will go for MRI brain to detect any structural lesion. Okay, so what about the other investigation? Electroencephalogram. Yes, so we have talked so many things about seizure, but we haven't talked a single word, said a single word about electroencephalogram. And I think you guys must be wondering what happened to electroencephalogram, EEG. Actually, electroencephalogram is not much helpful in the diagnosis of seizure or epilepsy, because in most of the cases the electroencephalogram is done between the seizure episodes, so it is not much yielding uh, for the detection of epileptic activities in the brain. Yes, in one type of seizure which occurs so frequently, you can go for electroencephalogram, and that is absence epilepsy. As absence seizure occurs in hundred thousands of times, if you do electroencephalogram, you will find the abnormality definitely. So what is the abnormality? This is called 3 Hz spike and dome pattern. This is the classical pattern. Just look at this. There is a small spike, and this is the spike. It is followed by a rounded dome. So this is the spike and this is the dome, and every second there are 3 such spike and dome. This typical pattern is characteristic of absence seizure. Other than absence seizure, the utility of EEG in the diagnosis of seizure is not much. So how to treat? Epilepsy treatment includes avoidance of the risky situations, because epilepsy can occur abruptly. So the risky situations must be avoided by the patient. Then avoidance of seizure precipitants. There are certain events that precipitates the occurrence of a seizure. And of course, anti-epileptic drugs. So what are the risky situations an epilepsy patient should avoid? The epilepsy patient should avoid driving, cooking, and swimming. If you visit the burn units of Dhaka Medical College or the newly made Burn Institute, Sheikh Hasina Burn Institute, you will find there will be a lot of burn patients who are actually patients of seizure, and they uh, got the burn while cooking. So it is very risky for the seizure patients going for cooking unless seizure is completely controlled for a few months. So these 3 important situations, very risky situations, should be uh, prohibited for the uncontrolled seizure patients: the driving, cooking, and swimming. And obviously another one I think I should mention is crossing roads unattended. That means the patient may develop seizure during crossing the road, so that will be a very dangerous thing. And the conditions that actually precipitate seizures, like fasting, lack of sleep, mental stress, physical stress, these should be avoided too, because these conditions, these situations, there is chance of uh, development of a seizure episode. So there are so many drugs that can be used for seizure, and the most common drugs used in our country are sodium valproate, carbamazepine, phenytoin, and phenobarbital. These 4 drugs are the most common ones. So anti-epileptic drugs should be given. So one thing you have to mention the patient that the drugs should be taken regularly. Once you have started the anti-epileptic drug, you cannot miss a dose, because missing a dose may lead to the occurrence of a more dangerous seizure type. The important thing in prescribing an anti-epileptic drug is the particular drug should be started at low dose, and then after certain intervals you have to increase the dose until the seizure is controlled or the patient develops side effects. And you cannot stop any anti-epileptic drug abruptly. So when seizure is not controlled with one particular drug, you then add another one, gradually increase the dose of the second drug, and when the seizure is controlled completely, then you can gradually decrease the first drug. Okay. So there is one thing that must not be forgotten. That is, anti-epileptic drugs cannot be stopped abruptly, and it will lead to a very dangerous type of seizure episode, which is called status epilepticus. We will discuss it later. Here, the common side effects of the anti-epileptic drugs. So, there are so many drugs. So we have only mentioned the most common two drugs used. That is, sodium valproate can cause hepatotoxicity, alopecia, and weight gain. And carbamazepine can cause a very serious looking skin condition, that is Stevens-Johnson syndrome. And hyponatremia is also very common in carbamazepine treated patients. And any anti-epileptic drug can cause ataxia, tremor, diplopia, and nystagmus. So how long you have to use the anti-epileptic drug? In fact, in one word, you have to use the epileptic drug very long time. In primary generalized epilepsy, yes, if there is no seizure activity for 2 years, then you can gradually reduce the dose of anti-epileptic drugs and make the patient drug-free. But in focal epilepsy, actually, it is not possible in most of the cases, because there is a focus, and when you can find the focus, you may not be able to treat it at all. So if there is a treatable focus, and you treat the you remove the focus surgically or by other means, and the patient remains seizure free for 2 years, then you can try. But in many of the cases, unfortunately, you cannot find the focus. Another thing is, even if you find the focus, it is not treatable. So in many cases of focal epilepsy, the anti-epileptic drug can be used, should be actually are used lifelong. So these are the 4 anti-epileptic drugs which are relatively safe in pregnancy. That is lamotrigine, carbamazepine, oxcarbazepine, and phenobarbital. Sodium valproate is most teratogenic. Now, what is status epilepticus? Very important topic. It means persistent generalized seizure for more than 5 minutes, or repetitive generalized seizures without complete regain of consciousness for more than 5 minutes. What it means? It means that seizure once started, it should be ended within 5 minutes. That is why in the definition of seizure, we use the term transient. So in status epilepticus, if the 5-minute mark is crossed, we call it status epilepticus. Or even sometimes the seizure may stop before 5 minutes, but it started again within the time, and between the 2 episodes there is no full regain of consciousness. So what is status epilepticus? It means that persistent or repetitive generalized seizures without complete regain of consciousness for more than or equal to 5 minutes. It is usually caused by abrupt withdrawal of anti-epileptic drug, and also some acute cerebral disorders like stroke, head injury, encephalitis may lead to status epilepticus. That is why it is very important to ask the patient not to miss a single dose of anti-epileptic drug. Okay, that is the reason, because status epilepticus is very dangerous situation. It is a medical emergency. The patient must be admitted. So how to treat? If the patient comes within 30 minutes, we call it an early status epilepticus. So the first thing is we have to start high flow oxygen and open an intravenous access. An IV channel should be opened, and the patient should be given intravenous diazepam. So this is what we do in the early part if the patient comes within 30 minutes. So if the seizure is not controlled with these measures, we can even give a second dose of intravenous diazepam, but all we have to do within 30 minutes. So if seizure persists despite all these efforts after 30 minutes, then we call it a established status. Okay. And established status epilepticus is treated with intravenous phenytoin, intravenous phenobarbital, or intravenous sodium valproate. So there are different options according to the availability. You can use either phenytoin, phenobarbital, or sodium valproate, obviously intravenously. So there will be a few patients which, even after giving these drugs, will have seizure persistently. And if that process 120-minute mark, we call it a refractory status epilepticus. And refractory status epilepticus is a very special situation to handle. You have to use the general anesthetic agents to control that seizure. Another important term is epilepsia partialis continua. So this is actually this is homologous. This is a similar term we used for generalized seizure as status epilepticus. So this is the status epilepticus of partial seizures. Okay. So this is either persistent or repetitive partial seizures for more than 10 minutes. So the 5-minute mark is changed for partial seizures, that is, it is made 10 minutes. So the definition is similar to status epilepticus. Another thing is, as in partial seizures there is no loss of consciousness, so this term is not without regain of complete consciousness, this term is not used here. So what is epilepsia partialis continua? It means persistent or repetitive partial seizures for more than or equal to 10 minutes. It is treated the same way as status epilepticus, that is, first by intravenous diazepam, followed by intravenous phenytoin, or phenobarbital or sodium valproate, and even after that intravenous general anesthetics. So before ending, there is an interesting term I want to share, which is called symptomatic seizure. This is generalized seizure due to systemic disorders. So there is no problem in the brain intrinsically, but some systemic disorder may lead to generalized seizure, like hyponatremia, hypoglycemia, hepatic encephalopathy, uremic encephalopathy. So these conditions may lead to generalized seizure. Actually, treating these primary conditions is good enough to control seizures. So otherwise, anti-epileptic drugs are not usually indicated in symptomatic seizures, except if the patient developed status epilepticus in symptomatic seizure, then you have to intervene just like you treated other status epilepticus. But otherwise, regular use of anti-epileptic drug is not required in symptomatic seizures. So I think we have come to the end of the lecture, and thanks a lot for us for the patient's hearing. So I should take a leave now, and obviously I will be a bit busy in the next month, in fact. So probably in the month of August we may not meet, but yes, of course, if I get time I will contact them and have a class in August. But till then, have a good time. And obviously, I think today's lecture, yes, I think that today's lecture was a relief for you people, because you didn't have to see my face. You could concentrate entirely on the shared screen. So I hope that this lecture has some effects on your studies. So I will see you hopefully after 1 month. Till then, goodbye and Allah Hafiz. Thank you.